Hello, my name is Schluenz, and today I'll be presenting the preliminary findings from my project looking at the effect of methocarbamol on opioid consumption in patients with traumatic rib fractures. Rib fractures have a substantial impact on injury-related morbidity in the U.S. and is accounted for up to 4 to 12% of trauma admissions. Currently, there is limited evidence on how to properly manage pain within patients with traumatic rib fractures. However, it has been reported that pain associated with rib fractures can be significant and contribute to chronic pain and disability. It's also known that providing early pain relief in rib fractures helps prevent complications. Although not specific to rib fractures, the American Pain Society recommends using a multimodal approach. Methocarbamol, also known as Ribaxin, is essentially acting nervous system depressant. It's been utilized for its musculoskeletal relaxant and sedative properties in various injuries. However, currently, its role in pain management therapy is not well defined. The objective of my trial was to review the current gap in literature and assess whether the addition of methocarbamol to rib fracture management, whether it reduces the amount of opioids consumed during the first 48 hours of a patient's hospital stay. My trial was a retrospective chart review that ran from January 1st of 2015 through September 30th of 2019. A total of 303 patients were used as a convenient sample with 139 included in the analysis. Inclusion criteria included all adults that had rib fractures due to traumatic injuries based off ICD codes. Patients that were excluded, the most common exclusion criteria was patients that were transferred from an outside facility or required surgery within 48 hours. The primary outcome of my trial was evaluating opioid consumption noted in morphine milligram equivalents in patients with rib fractures who received methocarbamol in comparison to those who did not. Secondary outcomes also evaluated the effect of methocarbamol on hospital length of stay in patients with rib fractures. And lastly, we also evaluated factors associated with increased morphine milligram equivalents in patients with rib fractures. This table here depicts some of the baseline characteristics. To summarize this, really patients were predominantly Caucasian, non-Hispanic males with a mean age of 54.3 years. Jumping right into results, as you can see with the first row there, we're looking at our primary outcome, assessing mean morphine milligram equivalents. And as you can see, there was no statistically significant difference in regards to morphine milligram equivalents in patients that received methocarbamol versus no methocarbamol. But as you can see with the actual milligrams, you can know that the trend is a little bit lower in patients who received methocarbamol versus those who did not. The bottom row there is assessing a secondary outcome looking at hospital length of stay, and as you can see, the average hospital length of stay was noted to be statistically significantly lower in patients who received methocarbamol versus those who did not. Other outcomes we assessed included a multivariate linear regression assessing factors that may be associated with increased morphine milligram equivalents. And what we found is that patients who were more likely to require increased morphine milligram equivalents were younger, male, and required mechanical ventilation. We also reviewed factors associated with increased hospital length of stay and noted that patients who had higher injury severity scores, required mechanical ventilation, and had no methocarbamol were more likely to have an increased hospital length of stay. Moving into the discussion, so the role of methocarbamol in pain management and traumatic rib fractures remains unclear. Additionally, there's very few studies that have actually evaluated the effects of methocarbamol on opioid consumption and hospital length of stay. I did just want to point out two different trials that did relate somewhat to my study. This first one was by Aluwani in 2017, and this study assessed pain control and for traumatic injuries comparing regimens with and without methocarbamol. They did find that there was no difference in pain control for non-specific traumatic injuries during the first 72 hours, but opposite of our finding, they actually demonstrated that methocarbamol group had higher opioid consumption. Additionally, a study done in 2017 by Pat and Walla looked at hospital length of stay in patients with closed rib fractures who received methocarbamol versus those who did not, and noted that methocarbamol had a reduced hospital length of stay similar to the findings in our trial. Some of the limitations of our trial include that we had a large exclusion population. This is likely due to the fact that we had many patients that were transferred from outside facilities, as we are our institution is specifically the state's only level 1 hospital, so we get many transfers from other institutions. Additionally, our study was limited to patients with rib fractures. And lastly, we did not assess adjunctive therapy, as this was up to the discretion of the provider, and the total daily dosing of adjunctive therapy was not accounted for. In conclusion of our preliminary results, we demonstrated that the addition of methocarbamol to rib fracture pain management did not significantly reduce total 24 and 48-hour morphine milligram equivalents, but was noted to have a reduced hospital length of stay. These are my references. That is all I have for you. My email is listed at the bottom. Please let me know if you have any questions. Thank you so much for listening.